Hello, this is chest pain semiology presented by the SchrDbb with reference a practical guide to history taking in clinical examination by Anwar Kials Sado. So you're going to visualize the chest pain. So what is chest pain? It just meaning pain on the chest. So although chest pain is common complaint in children, particularly in adolescents, it is uncommon presentation of cardiac disease and usually benign and self-limited. So usually this chest pain may be as a result of a hysteria, much more common in adolescents, for them to have an attention to their parents. So parents of child with chest pain are usually anxious and fearful. Therefore, reassurance is necessary to tell them that they may to exclude any serious cardiac condition. So differentiating the various chest pain from children. Okay, so if you have a musculoskeletal pain, how does it is it presenting it? So what are the first common pains? So you have musculoskeletal is very common. Traumatic pain is common, so an accident or a case of an abuse. So we have costochondritis, which is called Tietz syndrome, is also common. So the one which are much more superficial are common. So we have first is musculoskeletal pain, traumatic pain with accident or abuse is common. Costochondritis, which is Tietz syndrome, is common. Bronchopulmonary pain is common, like in case of asthma, pneumothorax, pneumonia, pleuritis, pleural effusion, and pulmonary embolism. All these have a bronchopulmonary pain which presents with a pleurisy. We have a gastroesophageal reflux is also common. We have coronary ischemia. So coronary ischemia, left ventricular outflow obstruction, and coronary abnormality are not very common in children, so they are less common, except you may have a Takayasu arteritis, which is much more in Japanese ethnicity. So you have acute pericarditis pain is rare, myocarditis pain is rare. You have arrhythmia is rare. You have psychogenic pain in case of hysteria is common. You have idiopathic chest pain is common. You have hyperventilation pain, chest pain is common. You have precordial catch syndrome or the Texidor twinge is uncommon, and we have the acute chest syndrome, which is more or less common. So we start with the musculoskeletal pain. It is frequently preceded by a history of unusual effort. So if you have a very high physical activity, you can think of musculoskeletal pain. It's usually sharp, well localized, is reproducible by specific movement or palpation. Are you getting? So that is for musculoskeletal pain. Traumatic pain follows the chest trauma. It is usually localized at the site of trauma. Costochondritis or Tietz syndrome, so present as a pain at the costochondral junction. So you touch the costochondral joint, that's costochondritis, usually the pain there, costochondral joint. It is more common in teenage female. The pain can be reproduced by palpation of the costochondral joints, that's in case of costochondritis or Tietz syndrome. The next one is bronchopulmonary pain. So for bronchopulmonary pain, you may be associated with fever, with cough, with dyspnea. So if you have fever, cough, dyspnea, wheezing or respiratory symptoms, think of bronchopulmonary pain. May worsen with respiration or deep breathing and may be reproduced by cough. There may be a history of respiratory disorders such as asthma. Now the next one is gastroesophageal reflux. So gastroesophageal reflux presents as a retrosternal burning pain, which can be diffuse, often occur after meals, postprandial, may awaken the patient from sleep and may be associated with sore throat. Often occur when the patient lies supine or bend forward. So if the patient lies supine, bend forward, you can have the pain and is relieved by antacid. So the next one, you have coronary ischemia, left ventricular outflow, obstruction, and coronary abnormality. Present as so coronary ischemia, left ventricular outflow, obstruction, coronary obstruction is not very common in children. It's presenting as a substernal pressure-like pain. Pressure-like pain usually occur with exertion. Often radiate to the neck, back, and left arm. May be associated with pallor, and so you can have ischemia pain may be associated with pallor, sweating, palpitation, or syncope. Are you getting? So those are the symptoms which the coronary can be associated with. Can be associated with pallor because the heart does not pump enough blood to the circulation. Can be associated with sweating. Can be associated with palpitation. Can be associated with syncope. So the next one is acute pericarditis. So acute pericarditis is characterized by acute onset of sharp stabbing chest pain. So if you have an acute onset of sharp stabbing chest pain, may be associated with fever exacerbated by inspiration and alleviated by leaning forward. So if a pain that is exacerbated by leaning forward is acute pericarditis, is alleviated by leaning forward is acute pericarditis. Another pain that alleviates when leaning forward is also an acute pancreatitis. So if you have characterized by sharp stabbing chest pain, may be associated with fever exacerbated by inspiration. Is alleviated by leaning forward, sitting upright, or prone position. But if you lie in the supine position, it's going to increase the pain. Myocarditis is a rare type of pain. It may present with chest pain with dyspnea, anorexia, and fever. It is usually preceded by febrile viral illness. Myocarditis. The next one is disease or underlying cause. You have arrhythmia, present as a rapid, forceful beat rather than pain. May be associated with dizziness or syncope. Psychogenic pain is non-specific in location and vague in quality. May be associated with family or school stress, other symptoms of anxiety or depression, recurrent somatic symptoms, and trouble sleeping. Psychogenic is much more associated, and it disappears with sleep. It's much more associated when the child wants to bring attention to himself. So we have idiopathic chest pain may be present as a recurrent chest pain for more than 6 months. A recurrent chest pain for more than 6 months usually occur at rest and no associated symptoms. You have no associated symptoms to the pain, but usually occur at rest and for more than 6 months. Think of idiopathic chest pain is very common. You have hyperventilation associated with lightheadedness, paresthesia, and underlying anxiety. You have precordial catch syndrome, which is a texidor twinge. So it's characterized by a sudden onset of severe sharp stabbing pain at the left sternal border, which is just like the acute pericarditis. Occur at rest, may be associated with bending or slush posture. So when you are bending forward, just like gastroesophageal reflux disease, actually be bending forward, slush posture, last seconds to minutes at most, and may be increased with breathing catches present in mid-inspiration. So if you have a pain that is sharp in character, sharp chest pain associated with bending forward, or with a mid-inspiration chest pain, is going to be much more a catch. So because of that mid-inspiration, catch means that what you want to do full inspiration, but at the mid you are stopping, you are catching your breath. So that it should not increase more because of the chest pain, you think of a texidor twinge. So acute chest syndrome, so it's usually uncommon, that texidor twinge or precordial catch syndrome. So we have acute chest syndrome is present as chest pain, shortness of breath, fever, cough in patients with sickle cell disease. So acute chest syndrome is mostly sickle cell disease having chest pain. So now, here we need to know that every time you want to characterize a pain, you use a mnemonic SchrDbb. S for the site, where is it located? done, and where is the point of maximal severity? You tell the patient to touch the point. Onset, you have, it can be sudden onset, which is foreign body in the esophagus. Chest injury should be considered in infants. We have arrhythmia, we have chest trauma, pneumothorax, all that. We have gradual onset, how the pain. So we have also onset again, it can be acute, which is less than 2 days. Acute chest pain, you need to know that the term acute and chronic is much more used in case of the term acute and chronic is much more used with respect to different symptoms. As you have seen before, cough had acute, subacute, and chronic, and acute cough was less than 2 weeks, subacute was 2 to 4 weeks, and chronic was greater than 4 weeks. But now you need to know that what an acute chest pain is less than 2 days. Are you getting? And chronic chest pain is more than 6 months, and in between is subacute. Are you getting? So if you say an acute chest pain is less than 2 days, it suggests an organic cause. It means that it is heart problem at some time. And if you have a very chronic chest pain, which is, it can be suggesting a psychogenic or an idiopathic cause, or even a precordial catch syndrome, an idiopathic chest pain, or a psychogenic chest pain. So all that. So those are the onset. And the character, is it squeezing in character? Is it sharp for pericarditis? Is it dull? Dull also is also pericarditis. Is it burning like in esophagitis? Is it squeezing like in the case of the cardiac ischemia? Radiation, does the pain radiate somewhere the left arm like in cardiac ischemia? Should I see there should be fever? If I should be fever, I think of pneumonia, pleuritis, pericarditis, myocarditis, any infection. Palpitation, you can think of an arrhythmia. Is it a syncope? May suggest arrhythmia or severe anemia. If you have syncope, actually you think of an arrhythmia, or you think of a severe anemia. You can also think of a cardiac ischemia. We have diaphoresis, easy fatigability, cyanosis, pallor, edema. We have the time course of the pain, progression. Does the chest pain follow a certain pattern, episodic? So is it intermittent? Is intermittent? When is it worse? And the time, is it more in the morning? What is the frequency? That's what you have to know there. The exacerbation and relieving factor, is it exacerbating with exercise, and is it relieving with rest? Is it exacerbating when you're taking a certain meal, gastroesophageal reflux disease? Is it relieving when you're coughing, breathing, or any movement? So severity, relationship of pain and sleep activity. So severity, you use a verbal numerical scale, or you use a visual analog scale that I've initially explained before. Now we have pain history. So for the pain history, we have exercise tolerance. So but for the past history, you have exercise tolerance. You have to know if it is actually with asthma, increased risk. Asthma people are increase of pneumonia or pneumothorax. Are you getting? The next thing is a recent event. Was there a muscle overuse, where you can think of a muscular pain, musculoskeletal pain? Was there a chest trauma, where you can think of a chest trauma pain? Was there a leg trauma? Acute chest pain may suggest pulmonary embolism. If you have a leg trauma that in a patient, and then you have a sudden acute chest pain, you can think of a pulmonary embolism, although rare in intrusion. So was there a recent viral illness? Was there gastroesophageal reflux disease, sickle cell disease, Kawasaki disease? Kawasaki disease can make you think of a cardiac ischemia, which can occur in children. So Kawasaki disease, we have a psychiatric problem. We have results of prior cardiac and test, ECG and echocardiogram. Medication issue, you have recent use of medication, oral contraceptive in adolescent girl, risk of pulmonary embolism, aspirin, steroids, non-steroidal anti-inflammatory drug, iron, tetracycline, drug allergies. Family issue of chest pain or sudden unexpected death may imply hypertrophic cardiomyopathy. If you have a family issue of chest pain or sudden unexpected death in a family, you think of a hypertrophic cardiomyopathy, you think of cardiorespiratory disease, you think of early coronary artery disease, you think of stroke in the family. So if you have a family issue with that, you think of hypertrophic cardiomyopathy as the first. cardiorespiratory disease, early coronary artery disease, stroke in that family, you have first degree relative with a congenital heart disease, recurrent syncope, sickle cell, non-genetic syndrome like Marfan or Turner syndrome. So social issue, you have stressful life, you have the use of certain things like cocaine, marijuana, or smoking, and then you have the relief system. Now, key points to note here in chest pain. The first thing, a frequent occurrence in chest pain over time is unlikely to be caused by serious organic pathology. So if you have a frequent chest pain, is not acute, is for a long period of time, you think that it is less likely that it's going to be an organic in origin. It's much more psychogenic or idiopathic. So a family history of early occurrence, that is less than 50 years of age, of myocardial infarction, angina, stroke may suggest. So if you have a family history of a chest pain or a family issue of a chest of a myocardial infarction, angina, stroke, you may think of disease problems like familial hypercholesterolemia. So you have to think of familial hypercholesterolemia. You have to think of thrombophilia, meaning that that family produces a high level of thrombophilia. You have to think of excessive anxiety in that particular family. The next, if the chest pain is associated with syncope, palpitation, cyanosis, or family issue of cardiac arrest, you should think of cardiac condition. If there is chest pain associated with syncope, family and palpitation, cyanosis, or family issue of cardiac arrest, think of cardiac condition. Sudden onset. So if you have sudden death in family, may suggest cardiomyopathy and familial. So if you have sudden death in the family, you think of cardiomyopathy or you think of familial arrhythmic disorder. Are you getting? So these are all the diseases that you have to note, the points that you have to note on chest pain. Thanks for your kind attention.